This is WHO edition 5th edition. So we are discussing about renal cell tumors introduction, epidemiology. The incidence and mortality rates of renal cell tumor have been increasing in many countries across different levels of socio-economic development. Incidence: renal cell carcinoma accounts for 2% of all the cancers globally. 2% of all the cancers globally and is the cause of 2% of cancer deaths. 2% of all the cancers in the globe, that is RCC, and whatever the deaths are happening in that 2% is because of the RCC. In 2020 there were 271,249, that means 2,71,249 new cases in men and 160,000 cases in the women. That is, the male female ratio is 1.24:1 in 1990 and 1.58:1 in 2017. Kidney cancer currently ranks as the 7th most common cancer. 7th most common cancer in men and 10th most common in the women. 7th most common cancer in men and 10th most common cancer in the women. The incidence is higher in the high income countries. Incidence is higher in the high income countries than in the low income countries, with the highest rates in the Belarus in the 2018, followed by Latvia, Lithuania, Czech Republic. Elevated rates of the kidney cancer are also found in northern and eastern Europe, North America and Australia. Low rates are reported in the Africa and Eastern Asia. I think this is because of decreased availability or no availability of investigations. So that must be a cause. So that's why it is seen in the high income countries more. Mortality: globally, deaths from the kidney cancer increased from 68,140 in 1990 to 138,000 in 2017, with those in the male patients exceeding those in the female patients in 2017. The total number of deaths was 89,000 something in male patients and 48,000 something in female patients. Kidney cancer is the 16th most common cause of death from the cancer worldwide. 16th most common cause of death from cancer worldwide. So here we have studied what it ranks. What is its rank? 7th most common cancer in men, whereas a 10th most common in 7th most common in men, whereas 10th most common in females, while in a death rates it is a 16th most common. 7th, 10th and 16th most common cause of a death disease. The case fatality rate is lower in high income countries. Overall mortality to incidence ratio is 0.4 than in a low and middle income countries, 0.5. Only 3.1% of the cases were diagnosed in the Africa, but 5.7% of the deaths occurred in this region. Etiology: what is the cause of it? Obesity. Obesity is a risk factor for a kidney cancer in both men and women. There is an association between the baseline body mass index and a renal cancer risk, with increased risk when raised body mass index is documented at age 50. So till the age 50, if you are obese, then you are a risk factor for a renal cell carcinoma. Weight gain of more than or equals to 20 kg between the age of 18 to 35 years. If you are a 18 to 35 year uh, person and your age has increased from 18 years to 35 years, more than 20 kg, or between the ages of 35 to 50 years, is a correlated with the renal cancer risk. The proportion of all cases of renal cancer attributable to being overweight or obese has been estimated at about 40% in the USA and up to 40% in the European countries. The mechanisms by which obesity influences renal carcinogenesis are unclear, with chronic inflammation in adipose tissue, and immune dysregulation potentially promoting carcinogenesis. Maybe obesity is because chronic inflammation in the adipose tissue. This might be a cause. Renal cell proliferation may be caused by sex steroid hormones through direct endocrine receptor mediated effects. Obesity associated with endocrine disorders accompanied by decreased levels of sex hormone binding globulin and progesterone, insulin resistance, and increased levels of growth factors such as IGF-1 may be factors in the renal carcinogenesis. No convincing association has been found between the ingestion of a red and processed meat, poultry or seafood and the risk of RCC. So these are not associated, are not proven. So the second most common is a smoking. Before that, we'll just see the incidence in the renal cancer. Here worldwide, the darker is the color, the more is the risk of cancer, renal cell cancer. So here you can see these regions are increased incidences. Whatever the box I am making, so these are the regions where there are increased incidence in the renal cell carcinoma. So these are a moderate range, here, and this whatever the region is there, including India, Africa, and such regions here, right, this is the region where there is very less incidences. So second association is a smoking. Cigarette smoking is causally related to renal cancer. Meta-analysis indicate that ever smokers have a higher risk of a renal cancer than never smokers. Wow, this is very nice line they have written here. Meta-analysis indicate that ever smokers have a higher risk of a renal cancer than never smokers. With a dose-dependent increase in the risk, dose-dependent increase in the risk related to the number of cigarettes smoked per day, and the risk decreases in the 5-year period after smoking cessation. If you cease the smoking, if you decrease the smoking by 5 years, the incidence or a risk factor will decrease. Epidemiology data on kidney cancer causation by smoking are often biased because cancer registries do not typically differentiate between the renal cell carcinoma and urothelial carcinomas of the renal pelvis, for which smoking is also a significant risk factor. In a study on a smoking prevalence among 30,282 patients with renal cancer, 50.2% were current or a former cigarettes smokers. When correlated with the histological types of RCC, the proportion of a current or a former smokers ranged from 38% in the patient with a chromophobe carcinoma to 61.9% in those with a collecting duct medullary carcinoma, suggesting that chromophobe carcinoma has a weaker association with the smoking than do other RCCs. So the next risk factor is hypertension. Before going to that, let's look at this table, renal cancer types. What are the renal cancer types here? Total number of cases in the Wilms tumor, rhabdoid renal tumor, kidney sarcomas, renal cell carcinomas, or unspecified, all malignant renal cases. So this is just a data. Just we'll move on from this data. So as we have seen in the previous pages, this is also the same geographical data but in females, all ages. Third cause is hypertension. Association rather is hypertension. Hypertension or its treatment has been shown to be associated with risk of renal cancer, independently of obesity, with an increased risk associated with the hypertension medication including diuretics. Acute kidney injury has been shown to correlate with the papillary renal carcinoma. So hypertension or its treatment, mainly diuretic use. We use hydrochlorothiazide. So these can be associated with the RCC. Acute kidney injury has been shown to correlate with the papillary renal cell carcinoma. Acquired cystic disease. Patients on a long-term hemodialysis due to an end-stage renal disease develop renal cysts and have an increased risk of renal cancer, that is 3 to 7%. They are 100 times more likely than people in the general population to develop a renal cancer. 100 times, because short, if you are hemodialysis on a long time hemodialysis, so short that you are going to be 100 times more risk that you are going to end up in the renal cancer. Some renal cancer types occur exclusively in an end-stage renal disease. These tumors show tubular, papillary, tubulopapillary, microcystic, solid patterns with tumor cells having abundant eosinophilic cytoplasm and a large nuclei. Abundant eosinophilic cytoplasm with a large nuclei with conspicuous nucleoli, including intracytoplasmic lumina and intercellular spaces that impart a cribriform sieve-like appearance. There is intercellular spaces are there. So this will give rise to sieve-like pattern. Sieve-like pattern it will give rise to, where these are the cells, holes are the cells, whereas this mesh is not a cell, rather a cribriform pattern. This is acquired cystic disease. In addition to these acquired cystic disease associated RCCs, all other subtypes can also occur in an end-stage renal disease. Fourth one is occupational exposure. A meta-analysis of association between the exposure to trichloroethylene, a solvent widely used as a metal degreaser and a chemical additive, trichloroethylene, and clear cell cancer reported significant relative risk of a 1.3 overall and 1.6 for high exposure groups. The International Agency for Research on Cancer has classified trichloroethylene as a group 1 carcinogenic to humans on the basis of it causing the kidney cancer. It is unlikely that coffee has a substantial effect or that alcoholic drinks have an adverse effect on the risk of this cancer. Whereas genetic susceptibility. In this 5th edition volume, the importance of a genetic tumor syndromes in the kidney neoplasia is emphasized in a dedicated chapter, genetic tumor syndromes of a urinary and male genital tracts. So now we will dwell into the genetics of renal cell carcinoma. In this 5th edition, there is a new category of a molecularly defined renal tumor entities. Tumor classification is a dynamic process integrating multiple new areas of information based on enhanced molecular interrogations. that have been conducted by numerous investigators since the publication of the previous edition. Attempts to classify RCC have traditionally been based on defining subtypes according to the predominant cytoplasmic or architectural features, with the consecutive identification of a specific genotype phenotype correlation. Example, clear cell RCC, papillary RCC, or a tumor location based on a collecting duct and a renal medullary carcinoma, correlation with background renal disease, that is acquired cystic disease associated RCC, resemblance of a tumors to the embryological structures such as metanephric adenoma, or a specific hereditary background which is a hereditary leiomyomatosis and a RCC syndrome associated RCC. The 2004 WHO classification first introduced tumor subtypes defined on the basis of a specific molecular alteration, that is translocation associated RCC. Translocation associated RCC. In recent years, studies have shown that some of these molecularly defined tumors have an overlie broad morphological spectrums without an equivocal genotype phenotype correlation. Therefore, molecular testing, including next generation sequencing, is increasingly used to classify RCC, and it has especially broadened the differential diagnosis of tumors considered in oncocytoma and chromophobe RCC category, which now include, let's read one more time. Therefore, molecular testing, including next generation sequencing, is increasingly used to classify RCC, and it has especially broadened the differential diagnosis of tumors considered in the oncocytoma and chromophobe RCC category, which now include fumarate hydratase deficiency RCC, epithelioid angiomyolipoma, TFE3 rearranged and TFE-B altered, TFE3 rearranged and TFE-B altered RCCs, and eosinophilic solid and cystic escape. Eosinophilic solid cystic RCCs. Eosinophilic solid cystic RCC can show TSC escape, can show task, escape from the task, you can remember like this: escape from the task gene mutation or a biallelic loss. Recent studies have identified many tumors whose cells have eosinophilic cytoplasm and oncocytic or a chromophobe like features in the RCC NOS group, with somatic inactivating mutations of TSC2 or activating mutations of mTOR as the primary molecular alterations. However, task, I can call it as a task associated, TSC associated and mTOR associated neoplasms are a very heterogeneous group morphologically and immunohistochemically. To gain a better understanding of this heterogeneous group of oncocytic tumors, which are not classified as oncocytoma or a chromophobe RCC, a category of unclassified oncocytic tumor has been introduced. This category of unclassified oncocytic tumor encompasses a low grade, it is low grade and a high grade oncocytic tumors, because the behavior of such tumors is poorly understood. So that's why they are keeping it as unclassified oncocytic tumors. They can be high grade, they can be low grade. These developments demonstrate that some RCC subtype represent completely different neoplasms. Some RCC subtypes represent a completely different neoplasm with differences in the morphology, pathogenesis, molecular events and prognosis rather than purely morphological defined subtypes. In contrast to brain tumors, it is not yet time for RCC to undergo a purely molecular classification. It is not possible. Just like a brain tumor, which is purely molecular classification, RCC cannot be purely molecular classification. And in contrast to previous edition of a WHO classification of urinary and male genital tumors, in this edition the editorial board has decided to first divide RCC into morphologically and molecularly defined RCC. Molecularly defined RCC include TFE3 rearranged, RCC ALK ALK rearranged RCC, TFEB rearranged, and TFEB amplified RCC, and ELOC formerly TCEB. It is called as a TCEB1 formerly, now it is called as a ELOC mutated RCC, and SMARC B1 deficient RCC, and others. RCC with a prominent leiomyomatous stroma frequently harbor mutation in the TSC, TASC1, TASC2, mTOR, ELOC. These tumors, RCCs with a prominent leiomyomatous stroma frequently harbor mutation in a TASC1, TASC2, mTOR, ELOC. These tumors may have considerable morphological overlap with the clear cell RCC and clear cell papillary renal tumors, supporting the hypothesis that ELOC mutated RCCs are identical and indistinguishable from a subset of hereditary tuberous sclerosis associated RCC, originally described as a renal angiomyoadenomatous tumor like RCC. Tuberous sclerosis associated papillary type RCC. So what they are telling is, these tumors may have considerable morphological overlap with the clear cell RCC and clear cell papillary tumors, supporting the hypothesis that ELOC mutated RCCs are identical and indistinguishable from a subset of a hereditary tuberous sclerosis associated RCC. Originally they were described, these tuberous sclerosis associated RCCs, originally they were described as a renal angiomyoadenomatous tumor like RCCs, or a tuberous sclerosis associated papillary type of RCCs. A clear diagnosis of a ELOC mutated RCC can only be made by complex molecular analysis. Therefore, it has been decided that this entity be put into the category of a molecular and defined RCCs. In contrast, although almost all metanephric adenomas, adenomofibromas, and metanephric stromal tumors are defined by a BRAF PV600E alterations, they are still regarded as a morphologically defined neoplasms. One important change in the 5th edition is the definition of papillary RCC. In 2016, it was hypothesized that type 2 papillary RCCs include different tumor entities. Since then, the essential and desirable criteria useful for the differential diagnosis of a fumarate hydratase deficient RCC, eosinophilic solid and cystic RCC, and translocation RCC have been further developed. Whereas the former type 1 papillary RCC is now regarded as a classic morphology of papillary RCC. The diagnostic criteria for type 2 papillary RCC need to be re-evaluated. Another change in the 5th edition is the name change, that is clear cell papillary renal cell carcinoma to clear cell papillary renal tumor, which was introduced in the 4th edition of the WHO classification. The name change was made because there are no reports of metastatic events for this indolent tumor entity. The category of nephroblastic tumors Neoplastic tumors described in this edition WHO classification of urogenital tumors are also included in the WHO classification of pediatric tumors. Neoplastic tumors are included in the pediatric tumors. Morphological data still remain of clinical relevance in the treatment of cancer patients. For example, sarcomatoid differentiation, which has been recognized as a feature of aggressiveness allows the selection of a tailored therapy, immunotherapy, and immune checkpoint inhibitors are under consideration for the first line treatment of the patient with the sarcomatoid RCC. At present, molecular profiles do not influence the care of the patient with the kidney cancer. Note it down. Molecular profiles do not influence the care of the patients with the kidney cancer in the setting of either surgery or systemic therapy. However, emerging data from the clinical trials of immuno-oncology agents used in the combination with or compared against VEGF inhibitors suggest that distinct gene expression signatures reflecting a prominence of angiogenesis or immune infiltration correlate with the response to therapy. And in the future, this could support personalized therapy choices. The exact correlation between the genomic alterations, including mutations, copy number alterations, and features of a tumor microenvironment, is under investigation. In terms of morphological features, the presence of a sarcomatoid differentiation is associated with an increased benefit from the immuno-oncological agents. It is worth noting that the evaluation of any potential biomarkers in the renal cell carcinoma is complicated by prominent intratumoral heterogeneity evident both at the genetic level and in the transcriptomic features. So these are the list of emerging renal tumors and their associated gene alterations. Proposed entity is the thyroid-like follicular carcinoma, eosinophilic vacuolated tumor, low-grade oncocytic tumor, biphasic hyalinizing psammomatous renal cell carcinoma, papillary neoplasm with a reverse polarity. So thyroid-like follicular carcinoma and biphasic hyalinizing psammomatous renal cell carcinoma are not present yet, whereas other oncocytic tumors, we include eosinophilic vacuolated tumor and low-grade oncocytic tumors, whereas papillary neoplasm with a reverse polarity is in the subtype of a papillary renal carcinoma. Like in the 4th edition, there is an emerging body of knowledge in this 5th edition that is compelling but not sufficient for placing certain clinico-pathological and genomically distinct tumors into a formal classification of renal tumors. This table 2.0.2, this is a summary of tumors currently regarded as an emerging entity. This table provides some information on how a few of these tumors may currently be classified. Interestingly, all of them have an underlying probably characteristic molecular alterations. Now this is the WHO classification of tumors. International Society of Urological Pathology, ISUP, or WHO, International Society of Urological Pathology, histological grading of a renal cell tumor. So we have divided the RCC subtype validated for WHO, that is clear cell RCC and papillary RCC. RCC subtype where WHO grading is clearly not applicable. So this we will discuss here in my PPT. It is there here. So this table is telling us where grading works and where grading doesn't work. So in clear cell RCC and papillary RCC, grading works and is important for prognosis. Whereas in chromophobe TFE3 rearranged, grading is not useful. Use other clues rather than grading. STH deficiency, fumarate hydratase deficiency, mucinous tubular or a spindle cell, ELOC mutated, TFEB, altered RCC, RCC NOS. Grading may help in some cases, but results can vary. Be conscious in this case. Collecting duct carcinoma, SMARC B1, deficient medullary carcinoma. Always high grade and aggressive grading doesn't matter. So collecting duct carcinoma, SMARC B1 deficient medullary carcinoma, these are always aggressive and high grade. So grading doesn't work here. Whether you grade it, doesn't matter. These are high grade. These are gonna be very aggressive. Those are collecting duct carcinoma and SMARC CB1. SMARC B1. Whereas tubulocystic carcinoma, there is a tubule, there is a cyst. Tubulocystic carcinoma, acquired cystic disease RCC, that occurs in the dialysing patients. Eosinophilic solid cystic vacuolated tumor. Grading can mislead you. These look high grade but usually behave well. These are very innocent tumors. Like someone is getting the dialysis, so that means it's not his fault, right? So that's why God is very kind to him. He has given him acquired cystic disease RCC. So it doesn't, it is not usually high grade. So that's why even if you see some high grade features, grading can mislead you. Eosinophilic solid cystic vacuolated tumor, tubulocystic carcinoma, acquired cystic diseases. So grading can mislead you. These look high grade but usually behave well. Whereas papillary adenoma, multilocular cystic neoplasm, multilocules. So many locules are there, cystic neoplasm, clear cell papillary tumors. So these are hybrid tumor, clear cell papillary tumor, papillary adenoma, multilocular cystic neoplasm. Grading is needed as a part of diagnosis, but they are usually low grade by their nature. So wherever papillary is coming, wherever clear cell is coming, there all grading is required. ALK rearranged RCC, not enough info about the grading or a clinical behavior is there. Other oncocytic tumors, grading doesn't match how dangerous these are. Ignore the grading, other oncocytic tumors. So that's about this table summarized in my PPT. So this is the grading of RCC. Currently, nuclear grade is integrated in several prognostic tools for a renal cancer, and where applicable, it is required to be reported in the nephrectomies by the International Collaboration on Cancer Reporting (ICCR) and other reporting guidelines and recommendations such as those of a College of American Pathologists (CAP) protocol. In the 4th edition of this volume, WHO Classification of Tumors, International Society of Urological Pathologists, that is WHO ISUP, histological grading of a renal cell tumor types was recommended specifically for a clear cell carcinoma, and a papillary RCC for a grade 1 to 3 tumor grade is defined by the degree of nucleolar prominence. It is defined by the nucleolar prominence. It is defined by the nucleolar prominence, whereas grade 4 is defined by the presence of nuclear pleomorphism. Up to 1 to 3, it is nuclear prominence. From grade 4, nuclear pleomorphism. Okay, nuclear prominence 3 up to 3, nuclear pleomorphism 4th grade. Tumor giant cells and a rhabdoid and a sarcomatoid features. All of these is seen in the grade 4. Nuclear pleomorphism, tumor giant cells and rhabdoid and sarcomatoid features. Although grading was not validated for other subtypes of RCC at the time those recommendations were made, the suggested approach was to report the grading for all RCCs for completeness with descriptions based on the WHO ISUP grading criteria. Since the publication of the previous edition and the continued description of newer subtypes RCCs or refinement of the criteria of recently described entities, the process of validation of a WHO ISUP grade in RCC subtype is still in progress. Clinicians rely on the nuclear grade. Therefore, in the table 2.03, we provide the state and understanding of a WHO grading in the context of a published literature. So this is the table 2.03. Where is the 2.03? So this is 2.03. To date, only clear cell and papillary RCC have adequate validated data for a clinical applicability. Several papers have shown that the WHO ISUP system is not applicable for a chromophobe RCC. There are RCC subtypes where WHO ISUP grading is potentially useful, so these tumors types should be graded and reported accordingly. Grading may be less relevant in certain RCCs where the nomenclature indicates the aggressive behavior, such as collecting duct carcinoma, or where low-grade nuclear features are essential for accurate histological classification. For some other tumor types, data are still evolving, with the clear instances where grading may be misleading or where the significance of grading is unknown. So these are all the things we have discussed in the previous page. Other tumor types. In this edition of the WHO classification of urogenital tumors, the category of a renal hematolymphoid neoplasm, is addressed in the chapter 11, hematolymphoid tumors and neuroendocrine tumors, NETs and hematolymphoid tumors, NETs and HALTs. Hematolymphoid tumors, NETs and HALTs of the kidney are addressed in chapter 9, neuroendocrine neoplasm, where these tumors are described for all the organs within the genitourinary tract. Similarly, metastases of the kidney are included in the chapter 13, metastasis in the genitourinary system. The mesenchymal tumor unique to the kidney are described in the chapter 2, tumors of the kidney. Mesenchymal tumors deals increased knowledge about the hereditary tumor syndromes, and a renal neoplasia is highlighted in the chapter 14, genetic tumor syndromes in the urinary and male genital tracts. So coming to the clear cell renal cell carcinoma. Clear cell renal cell carcinoma is a morphologically heterogeneous malignant tumor. It is heterogeneous. It is heterogeneous malignant tumor derived from renal tubular epithelial cells. It is derived from the renal tubule epithelial cells. Suppose this is renal tubule. Okay, these are epithelial cells, right? From these epithelial cells, this clear cell is coming. The neoplastic cells have predominantly clear and occasionally eosinophilic cytoplasm, accompanied by an abundant network of blood vessels, and associated with the biallelic VHL inactivation. Localization. Clear cell RCCs are usually solitary within the renal cortex. So this is renal, this is medulla, this is cortex, right? Solitary, that means single will be there. Single solitary renal cortex occurring equally in the either kidney, or less than 5% of the clear cells are a multifocal or a bilateral, and together with an early stage of onset, this suggests a hereditary cancer syndrome. Together with an early age of onset is there. Suppose the patient has this kidney tumor, and he is old patient, that means it is a clear cell RCC. But suppose this patient is a young patient, then it suggests that a hereditary cancer syndrome such as a von Hippel-Lindau syndrome, VHL, von Hippel-Lindau syndrome. What are the clinical features and symptoms? Clinically, symptomatic renal cell carcinoma can cause hematuria. And flank pain with weight loss, and fever. In the late stages, asymptomatic tumors are detected radiologically with the ultrasound, CT, MRI, because clear cell carcinoma have propensity to metastasize hematogenously. These are hematogenously they will metastasize. Suppose this is blood is there, this is ureter, but blood vessel is here. From here they will start metastasizing hematogenously. They may manifest at a metastatic sites even before the primary renal tumor is discovered. Hematogenous spread through the renal sinus veins, and vena cava leads to pulmonary metastasis. So this is the blood, this is the kidney, this is the renal vein, this is the sinus veins, and this is a vena cava. So what happens is this will metastasize to the pulmonary, these will metastasize to the lungs. So lungs will be having these mets. This is pulmonary metastasis. Tumor extension into the lumbar veins allows spread to the low pressure paravertebral venous plexus that connects to dural venous sinuses superiorly and pelvic veins inferiorly, thus resulting in the metastasis to the CNS, head, neck, bone. These diverse metastasis pathways enable the clear cell RCCs to metastasize to the unusual sites such as a pancreas and a gallbladder. So through the sinus veins, through the renal vein, through the vena cava, we have seen it will spread to the pulmonary. So pulmonary metastasis. Now tumor extension into the lumbar veins will spread to the low pressure paravertebral. So this is vertebra. Suppose this is vertebra. So these are paravertebral veins are there. Venous plexus are there. That connects to the dural venous sinuses above. Dural venous sinuses above superiorly, and pelvic veins inferiorly there are pelvic veins, thus resulting in the metastasis to the CNS, head and neck, bone. These diverse metastasis pathway enable the clear cell carcinoma metastasis to the unusual sites such as the pancreas and gallbladder also. Epidemiology. Clear cell renal cell carcinoma is the commonest type of a sporadic RCC in adults according to 60 to 70% of the all RCCs. This is the most common RCC developed in the patient aged more than or equals to 60 years. Total overall incidence rate is estimated to be 3.59 and incidence is significantly higher in the men than in women and higher white people than in black people. So there is a man, right, who is a white man, will be having a increased incidence. He is a smoker also, he is obese also, that means it is having a higher incidence of renal cell carcinoma. The cause: most clear cell carcinoma, renal cell carcinoma are sporadic. These are not genetic, these are sporadic, these are not spread genetically, right? Rarely they may be observed in the various familial settings. Tumors associated with the germline mutation of VHL, von Hippel-Lindau syndrome, manifest as a multiple clear cell renal cell carcinoma and renal cysts. Cyst will be there, see, multiple cyst will be there and multiple RCC will be there, okay, in the von Hippel-Lindau syndrome. And at a younger age, they will present at the younger age than the sporadic clear cell renal cell carcinoma. Clear cell renal cell carcinoma have been reported in the various other familial cancer syndromes such as constitutive chromosome 3 translocations, BAP1 tumor predisposition syndrome, Cowden syndrome, Birt-Hogg-Dube syndrome and tuberous sclerosis. Clear cell renal cell carcinoma have been reported in the various other familial cancer syndrome. These are some of the familial cancer syndromes such as chromosome 3 translocation, BAP1 tumor predisposition syndrome, Cowden, Birt-Hogg-Dube and tuberous sclerosis. In these also we have seen RCC incidences. Although the tumors in some of these tumors may now be reclassified as an emerging entity rather than the clear cell RCCs. So whatever occurring RCC occurring from chromosome 3 translocation, BAP1, Birdhog Dube, Cowden and tuberous sclerosis, this is now all comes under the umbrella of emerging entities rather than the clear cell RCCs. A number of risk factors have been reported, including the smoking, obesity, long-term dialysis, hypertension, diabetes mellitus and exposure to the aristolochic acid, asbestos and trichloroethylene. So how is the pathogenesis of clear cell carcinoma? Suppose this is a chromosome 3, right? This is chromosome 3. In the short arm of a chromosome 3 is a ubiquitous somatic event accompanied by the inactivation of a remaining VHL inactivation gene by mutation or a mutation, or there is a methylation. Because of this, what happens, the VHL gene product VHL protein, which is a VHL protein, is a component of a E3 ubiquitin. One of the component is a VHL protein ligase, E3 ubiquitin ligase complex, a key regulator. This will what happen E3 ubiquitin ligase, it will regulate something called as a hypoxia, cellular response to hypoxia, HIF1. It will regulate this. What happens is substrate including HIF1 alpha, loss of VHL. This loss of VHL will result in the VHL protein loss. This will lead to the regulation E3 ubiquitin ligase complex loss. This will lead to the regulation loss of HIF1. When HIF1 alpha is unregulated, leading to the constitutive expression of HIF targeted genes. Mutations in genes encoding other members of the E3 ubiquitin ligase complex such as ELOC, CUL2 occur rarely and they are mutually exclusive with the VHL mutation, although these are differences between the tumors with the mutations in the ELOC and those with the mutation in the VHL. Dysregulation of the VHL pathway may explain their overlapping morphology and immunohistochemical profile. Loss of chromosome arm 3p result in the simultaneous loss of 3 other tumor suppressor genes that are frequently mutated in the clear cell carcinoma, which are PBRM1, SETD2 and BAP1. So there is a loss of 3p chromosome loss. If it is lost, then there is a mutation in these things, SETD, BAP1, PBR1. These are what? These are tumor suppressor gene. If your tumor suppressor gene is very lost, then what happens? Tumor will not be suppressed, it will start to proliferate. PBRM1 and SETD2 mutation frequently coexist. In contrast, PBRM1 and a BAP1 mutations tend to be mutually exclusive and the tumors are phenotypically different. So BAP किसी से मिलता नहीं है, whereas PBRM1 and SETD2 they coexist, whereas BAP अपना ही काम करता चला जाता है. The tumors are phenotypically different, so that's why PBRM1 and PAP1 mutations are phenotypically very different. Additional driver mutation and somatic copy number alterations include inactivation mutation in the histone modifying gene, activating mutation in the mTOR pathway gene, and loss of TP53, losses of a chromosome 14 and 9. Varying driver gene alteration underpin clear cell RCC evolution and biology. Clear cell RCC with the von Hippel-Lindau loss as the only driver event are indolent and they rarely metastasize. Like VHL, PBRM1 is often mutated Early during tumor development, PBRM1 mutated tumors with a subsequent SETD2 mutation drive a somatic copy number alterations or PI3K pathway alterations have a more attenuated disease course. In contrast, clear cell RCC with a BAP1 mutation or a multiple driver mutation have aggressive, BAP is very aggressive phenotypes with early dissemination of the disease. In addition, these molecular changes may influence metastatic organ tropism. Recent large-scale gene expression analysis of a metastatic clear cell RCC identified unique molecular subsets with a distinct drug response characteristics. Clear cell RCC with a strong angiogenic gene signature had a favorable response to anti-angiogenic therapies. Clear cell RCC with a strong angiogenic gene signature had a favorable response to the anti-angiogenic therapies. Of course, if it is angiogenic, anti-angiogenic therapies if you give, then it will be good response, and were enriched for PBRM1 loss. And in contrast, clear cell RCC with an inflamed microenvironment were associated with the highest expression of PDL1, preferentially responsiveness to regimens containing immune checkpoint inhibitors, and the highest rates of sarcomatoid change and BAP1 mutation. Coming to the gross appearance or macroscopic appearance, the size of a clear cell RCC is variable, ranging from 12 to 140 mm, that is 14 centimeter, with a more recent study reporting range of 2.3 centimeter to 17 centimeters. An increasing use of imaging has increased the frequency of a detection of a small tumors. The tumor usually has a round to oval pushing expansile appearance protruding from the renal cortex and sometimes displaying a pseudocapsule. The cut surface is usually golden yellow with a frequent hemorrhage, giving a variegated reddish yellow color. Fibrosis and calcification may be present. In low grade tumors, cystic change is frequent. In low grade, it is cystic change. It is very, this low grade is very innocent. It will start crying. It will go for a cystic change. High grade RCCs, these will not cry. They will stick as a stone, whitish firm areas with a frequent necrosis, often accompanied by extension into the renal vein and the perirenal and renal sinus fat. Now coming to the histopathology, HPR slide. Okay, the classic histological appearance of a clear cell renal cell carcinoma is nested. If you want to tell one word, it is nested tubular alveolar growth pattern, composed of cells with a optically clear cytoplasm. However, morphological variations are common, including cysts, are there hemorrhage, degenerative scar-like component. There is a complex vascular network with a capillary surrounding the essentially every nest. Suppose this is a nest is there, lots of cells are there, lots of clear cells are there like this, and there is a complex vascular network is there around these nests, which can be diagnostic clue to discriminate it from the neoplasm like a chromophobe RCC. Rarely, this may lead to the mimicry of a vascular neoplasm if the epithelial component is less conspicuous. Epithelial component is more prominently visible than the vascular, then vascular neoplasm can be suspected. With increasing grade, it is not unusual for tumors to contain eosinophilic cells or hyaline lobules. So as the grade will increase from the grade 1, grade 2, grade 3, then eosinophilic cells will increase. So this is a grade 1 nuclei with the nucleoli that are absent to inconspicuous at a 400x. Grade 2 here uh, here you can see that in a 400x also nucleoli is not visible, whereas in the grade 2 a light nucleoli are there. You can see here, right? So these are nucleoli, 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 nuclei. Conspicuous nucleoli are there. Whereas in a grade 3 you can see prominent nucleoli everywhere. Here, 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 here nucleoli are there, you know. You can see that nucleoli, right? So even in the low power 100x, that means 10x, you can see the nucleoli. Here you cannot see the nucleoli. Here moderately you can see the nucleoli. Here very prominently you can see the nucleoli. So while we are discussing this, let's see the grading here. So this is a grade 1. We can divide this grading as a easy understanding that grade 3 is dependent on the nucleoli, whether it is conspicuous or not, right? Prominence, which is dependent on the nucleoli prominence, whereas grade 4 it is dependent on the nuclear pleomorphism, tumor joint cells, and amount of a sarcomatoid rhabdoid differentiation. So that is clear, right? Grade 4 is clear. Now coming to the grade 1, 2, 3. So 1, 2 you can classify as a 400x and 3 as a 100x. 400x, if you cannot see the nucleoli, then it is a grade 1. If you can and cannot see, that is conspicuous, then it is grade 2. Whereas a 100x nucleoli are prominent and seen and eosinophilic, then it is a grade 3. So this diagram or HPR slide, clear cell carcinoma, the example shows the rhabdoid cells with ample pink cytoplasm and eccentrically placed abnormal nuclei, indicating grade 4. So here you can see, right, where I can show you, here is a cell, right? There is a abnormally placed nucleoli here, abnormally placed nucleoli, eccentrically placed nucleoli, right? Everywhere there is extrinsically placed nucleoli are there with rhabdoid cells, right, with ample of a pink cytoplasm. Nearly clear cell is a should be center and less eosinophil is there, should be there. But here what is happening is the cell eccentrically placed nucleus, whereas this cytoplasm is pushing the nucleus that side, that is rhabdoid. Coming to the B, necrosis within the tumor. This is a necrosis area, necrosis within the tumor. This example C includes the necrosis, rhabdoid cells and multinucleated cells. These are multinucleated cells, these are rhabdoid cells, okay, and necrosis is also there somewhere, necrosis, okay. So with increasing grade, it is not unusual for a tumor to contain eosinophilic cells and hyaline globules, which may be misleading if the cell with the clear cytoplasm are not prominent, especially in the biopsy sample. Other morphological variations that may be deceptive include the branched glandular structures or a nuclear alignment resembling clear cell papillary RCC. High-grade tumors sometimes contain bizarre giant multinucleated cells. Sarcomatoid and rhabdoid features may be found in the high-grade tumors, although these are not unique to this tumor type. Histological grading according to the WHO Classification Tumor International Society. Histological grading of renal cell we have seen has been shown to significantly predict the cancer specific survival. Grading is based on the nucleolar prominence, eosinophilia, or a grade 1 to 3, and on prominent nuclear pleomorphism. Note that nucleolar prominence and nuclear pleomorphism with a tumor giant cell sarcomatoid rhabdoid differentiation and no grade 4. As clear cell renal cell carcinoma commonly displays grade heterogeneity, the current recommendation is that the grading should be based on the highest grade represented by at least one high power field. the area of which has not been specifically defined, although it is approximately 0.23 millimeter squares in most modern microscope. A recent study has shown that although cancers with a overall grade 4 morphology had a significant worse outcome than grade 3 cancers, those with a 10% less than 10% grade 4 component were not associated with a significant survival difference from the grade 3 cancers. The study also demonstrated a significant difference in the survival between tumors with a less than 10% versus more than 50% grade 4 areas. That means what they are telling is whether it is a grade 4, grade 3 or a grade 4, there is no difference in the survival. That's a simple explanation. Differential diagnosis. The differential diagnosis of a clear cell RCC includes a clear cell papillary renal cell tumor, MIT family, a translocation RCC and chromophobe RCC, and multilocular cystic renal neoplasm of the low malignant potential, multiloculated cystic renal neoplasm of a low malignant potential using immunohistochemistry positivity for a PAX8 can be used to support the renal tubular origin. PAX8 will tell you renal tubular origin. Renal tubule is there, right? Renal tubular origin. PAX8 will tell you. We have discussed that, right? Clear cell will arise from the epithelium of the tubule, right? This is IHC. In IHC, we'll talk as a PAX8. So how we can remember is that tubules are packed with the epitheliums. PAX8. However, this overlaps with the other neoplasms, including those of thyroid, gynecological tracts, which are also commonly positive for a PAX8. Some upper tract urothelial carcinoma are also positive for this tumor. So, what they are telling is gynecological tract and upper tract urothelial carcinomas are also positive for PAX8. Clear cell renal cell carcinoma often has a dual expression of a cytokeratin markers such as CAM5.2, AE1, A3 and vimentin. So cytokeratin marker and vimentin, so dual expression will be there in a clear cell RCC. However, in a given tumor, the labeling for a single cytokeratin marker may be limited. Vimentin labeling is more common with a higher grade. So we have discussed, right, grade 1, grade 2, grade 3, grade 4 of the RCC. So here in the grade 4, as the grade will progress, the vimentin will increase. And it contrasts with the typical absent labeling in a chromophobe tumors. KIT is typically negative. KIT is not found in the clear cell. Unlike in the oncocytoma and chromophobe RCC, CA9 is a part of a hypoxia pathway related to the VHL and shows extensive membranous immunohistochemical labeling diffusely throughout the tumor, contrasting with the usually focal labeling associated with necrosis and ischemia in other tumor types. Labeling for a CA9 may be decreased with a high grade, poorly differentiated tumors. So what they are actually telling in summary is that grade 1, grade 2, grade 3 and grade 4 are there, no? In higher grade you can see the vimentin, right? In lower grade you can see the CA9. So as the grade will increase, vimentin will increase. As the grade will increase, CA9 will decrease. So as the grade will progress, vimentin will increase and 9 will decrease. So that's what they say. CK7 usually shows negative, only focal labeling of a clear cell renal carcinoma, but it often marks cystic areas. 7 is used for cystic. 7 is for cystic. And diffusely labeling in a rare tumors does not necessarily preclude the diagnosis. In contrast to clear cell papillary renal cell carcinoma. Clear cell renal carcinoma usually shows limited CK7 labeling, positive CD10 labeling, and variable ACR labeling, and it is usually negative for the high molecular weight cytokeratin and GATA3. Clear cell papillary renal cell tumor also discloses a cup-like pattern. CA9 reactivity, which differs from the circumferential reactivity observed in the clear cell renal cell carcinoma. What they are telling is clear cell papillary CP renal cell tumor also discloses a cup-like pattern of a CA9 reactivity, which differs from the circumferential reactivity observed in the clear cell renal cell carcinoma. Cup is seen in the CP. Cup is seen in the CP, while as circumferential we'll see in the clear cell. Of what marker? CA9 marker, that you remember. 9 marker, cup is seen in the CP, that is clear cell and papillary. Circumferential seen in the clear cell. RCC antigen is also commonly positive in the clear cell. Ultrastructural examination demonstrated that the clear cytoplasm results from the abundant lipid and glycogen. What we are seeing here, the clear cell here clear cells are there, no? This is because of the fat and glycogen. So cytological diagnosis of RCC is useful in determining whether the metastatic lesion is a primary renal origin with the cytological features depending on the histological tumor type. FNA, that is fine needle aspiration cytology of clear cell renal cell carcinoma, yields a cohesive clusters of clear cells with a variable nuclear and nucleolar appearances. These are cohesive structures will be there, they are telling. Cohesive structures of clear cells are seen in the FNAC, usually accompanied by a fine vascularity. Fine vascularity will be there in this cohesiveness. Fine vascularity. Differential diagnosis workup of a metastatic clear cell malignancy can be assisted by the immunohistochemistry on a cell block preparation. Cytology is also useful in the primary diagnosis of a radiologically indetermined renal mass of an advanced renal cancer where surgery is contraindicated. Advanced renal cancer where surgery is contraindicated, there you can use FNAC. And FNAC is often obtained in a conjunction with a core biopsy. Imprint smears of a core biopsy may also be analyzed cytologically, whereas clear cell renal cell carcinoma may be readily recognized in the cytology specimen. Mimics such as a benign renal tubular epithelial cells harboring clear cytoplasm, oncocytoma, angiomyolipoma, and other histologically types renal carcinoma should be carefully considered. Diagnostic molecular pathology. Inactivation of the VHL complex is the defining signature event in a clear cell renal cell carcinoma. Loss of chromosome arm 3p and inactivation of intragenic mutation or a promoter region methylation of a second VHL allele occurs in most 90% sporadic clear cell carcinoma. Loss of 3p may be identified through the molecular cytogenetic chromosomal microarray studies. Absence of these alterations is very rare and may cause such RCCs to be misclassified, although it is uncommon for all these aspects. To be evaluated in a diagnostic practice, VHL inactivation results in overexpression of HIF alpha, HIF1 alpha, as we have discussed. VHL will lead to the VHL protein, which is ligated to the E3 ubiquitin ligase, which will regulate HIF1 alpha. This regulation will be lost. So there is overexpression of HIF1 alpha, HIF target genes such as those involved in the angiogenesis, glycolysis and glucose transport, and erythropoiesis that molecularly characterizes clear cell RCC. So what happens is HIF1 alpha will increase and HIF target genes such as those involved in the angiogenesis VEGF alpha, glycolysis, that means glycolysis and glucose transport, and erythropoiesis, all this will increase, will leading to the characteristic clear cell carcinoma. Essential and desirable diagnostic criteria are renal mass showing solid, nested, tubular, hemorrhagic, alveolar architecture composed of clear cells with fine arborizing vascularities. Desirable is a immunohistochemistry positive for a CA9 or a molecular identification of the VHL mutation or a chromosome 3p loss. So how is the desirable diagnostic criteria is means in IHC you will see CA9, in a molecularly you will see VHL or chromosome 3p loss, VHL loss, chromosome 3p loss in molecular diagnosis, whereas in IHC CA9 positivity. So staging, kidney confined tumors are staged according to the primary tumor stage. Cutoff points are of 4 centimeters to 7 centimeters and 10 centimeters. Regional extrarenal spread PT3. So this is TNM staging, right? We will discuss this TNM staging in very detail here in my PPT. So let me open that PPT for you. This is the TNM staging, right? So this we have discussed in here. There is a T1, there is a T2, there is T3 and T4, right? In T1, T2, T3 renal in the kidney only this is localized. In T4 it is non-contiguously metastasized. In T3 it is contiguously metastasized to the adrenal glands. T1 and T2 depends on the size. So all of these three T1, T2, T3 is limited to the kidney. Okay. So in a T1, if it is less than or equals to 7 centimeters, then it is T1. If it is more than 10 centimeter and confined to the kidney, it is T2. In T1 and T2, there is A and B. A means less than or equals to 4 centimeter. B means less than or equals to 7 centimeter. Whereas T2 less than or equals to 10 centimeter, less than or equals to 10 centimeter or more than 10 centimeter. This is less than or equals to 10 centimeter is A, more than 10 centimeter but confined to the kidney is B, that is PT2B. Whereas T3 is confined to the kidney only, but it will spread to the it will not spread to the ipsilateral adrenal gland, it will not spread, whereas a T4 it will spread to the ipsilateral kidney. What is the specialty of T3 means? T3 has 3 classifications A, B and C. In A you can see the extension to the renal veins and segmental branches, invades the pericalysis system, invades perirenal and perirenal sinus fat, not beyond the Gerota's fascia. In B you can see the spreading to the vena cava. B and C you can see the spreading to the vena cava, but the difference is below the diaphragm. Below the diaphragm is B and above the diaphragm is C. Vena caval spread, below the diaphragm is B and C is above the diaphragm. Whereas 4 is spreading to the Gerota's fascia. This is contiguous spread and into the ipsilateral adrenal gland. See, in T4 what happens, suppose this is a kidney and this is adrenal gland, there is a contiguous spread to the adrenal gland and gyrotas fascia, whereas metastasis is a non-contiguous spread to the adrenal gland. Non-contiguous spread means this is a vein, from vein it is spreading to the adrenal gland. Contiguous means from directly to the kidney it is spreading to the adrenal gland. Prognosis and prediction stages at a presentation, nuclear grade stage, what are the stage, nuclear grade, sarcomatoid and rhabdoid differentiation, tumor type, necrosis, all predict the outcomes. Different forms of necrosis may be seen in the clear cell renal cell carcinoma. Thromboembolic infarct results in the coagulative necrosis, and this is distinctive from a tumor type necrosis. Extensive necrosis in the setting of the low grade RCC. Necrosis in case of a low grade RCC appears to be associated with the more favorable prognosis. Means there is a necrosis but it is a low grade RCC, that means favorable prognosis. Tumor type necrosis, known as a granular necrosis, has been shown to be an independently significant predictor of a less favorable outcome. That means if a tumor has a necrosis, then it is very bad. It is very bad. In especially clear cell renal cell carcinoma. Sarcomatoid differentiation results in the biphasic tumor with a varying amount of the fibrosarcoma like pleomorphic, undifferentiated, unclassified morphology. Heterologous differentiation such as a chondrosarcoma, osteosarcoma and rhabdomyosarcoma is rare. Rhabdoid differentiation is characterized by the solid sheets discohesive single round to polygonal cells with globular cytoplasmic eosinophilic inclusions and eccentrical large pleomorphic nuclei. Not uncommonly, sarcomatoid and rhabdoid differentiation coexist. Both these types differentiation are associated with a poor outcome. That means if they are having a sarcomatoid rhabdoid, it is very poor outcome. With a 15 to 22% 5-year cancer specific survival for tumors with a sarcomatoid differentiation. With rhabdoid differentiation, cancer specific morphology is mortality is 40 to 50% and median survival time is 8 to 31 months have been reported. So this is all about the clear cell renal cell carcinoma. Here we will see some diagrams are there and tables we have missed. Differential diagnosis of clear cell renal carcinoma. Here we are seeing the different IHC markers, morphology. In clear cell, nests are there composed of cells with a clear cytoplasm visible, variable cyst and a scar, eosinophilic cells prominent. So CA9 is positive, diffusely positive, whereas CK7 is negative. Amaker is a weak to strong, whereas vimentin often is positive in the especially high grade. As we have discussed, right, grade 1, grade 2, grade 3 and grade 4. Grade 4 usually we will see vimentin, grade 1 usually we will see grade 9. Whereas 7 is negative or rarely diffusely positive. 7 is seen in the cystic. Amaker is a variably positive, weak to strong. KIT is negative. GATA is 3 is negative. Cathepsin is negative. Key genetics are VHL, chromosome 3p, 25 loss. Coming to the chromophobe, nests are there, trabecula pattern is there, cells of variable size with a prominent borders, wrinkled nuclei. Is usually negative for 9, diffuse in CK7. Amaker is a weak, vimentin is negative. KIT is positive, right? KIT is very positive here in a chromophobe. Chromophobe KIT. Cathepsin is negative, GATA3 is negative, sometimes positive. HMWCK negative, GATA3 is sometimes positive. Multiple chromosome loss is there in a chromophobe. Phobe means it is scared of chromosomes. Clear cell RCC, clear cell, papillary RCC, cysts are there, branched glands are there, solid growth is there, papillary formation, all with a clear cytoplasm. So there is a clear cytoplasm is there with the papillary formation, solid growth is there. Diffusely positive for 9 because it is clear cell variant is also, but the difference is cup shaped. CP, right? CP, cup shaped. CK7 is diffuse, negative for Amaker, positive for Vimentin, negative for KIT, often positive for GATA3. This is differentiation, right? GATA3. GATA3 is positive in a CP. CP GATA3 is positive, whereas it is negative or a rare in a clear cell. So negative for cathepsin as usual, key genetics is none. MIT family, translocation, variable, clear and eosinophilic, solid and papillary formation. Sometimes samoma bodies are seen, hyalinized stroma. 9 is negative, CK7 is negative, Amaker is variable, often negative for Vimentin, also negative, negative for KIT, negative for GATA3, may be positive for cathepsin. MIT means cathepsin, that you remember. TFE3, TFEB, MIT, rearrangement is there. Papillary and tubular structures, variable basophilic, eosinophilic and samoma bodies. Papa, foamy macrophage. Papillary means papa. Papa is very aggressive, angry, and CMET is seen here. Men, papa is men, and P for papa, P for samoma bodies. So that's how you can remember as a mnemonic. So 9 is negative, usually positive in a basophilic or a clear, diffusely strong in a Amaker. So remember, papillary means Amaker. Vimentin is often positive, Vimentin and Amaker, all is positive. Papa, who will Papa love? Papa loves Amma, right? Amaker. And Papa always asks you why for Vimentin. Negative for KIT, maybe positive for HW, GATA3 is positive, rare subset, negative. MET mutation as we have seen, CMET, trisomy 7 trisomy, loss of Y. Papa is Y, right? Papa is male, Y. So that's how you can remember. So that's it for the video. That's about clear cell renal cell carcinoma.